We can see it.
You can see that?
Yes.
Brilliant. Thank you, Andre. So welcome, everybody. My name's John MacArthur. I'm one of the orthopaedic consultants in Coventry, and I've been asked to talk to you today a bit about pelvic ring injuries in particular, and particularly focusing on their initial management. So it's a big subject, but what I'm hoping to cover today is a little bit about the mechanism of injury and the classification of pelvic ring injuries. We'll focus on the initial resuscitation and what we can do to these patients sort of in ED and in the hyperacute phase. We'll talk a bit about the associated injuries that are commonly seen with these, and the particular focus on open fractures because they're a pretty important subsection of these injuries. So pelvic ring injuries tend to fall into two categories. They tend to be the high energy ones that we all get a bit worried about. This is the RTCs, the falls from a height. Commonly in civilian settings, particularly it's blunt trauma, it's motorbike accidents. Rarely we can get blast injuries and penetrating injuries. And these patients tend to be younger, although seemingly we're seeing more and more sort of born again bikers, which are a real challenge, you know, high energy, but softer bone, worse physiology. And then the second category we've got to be low energy, and this is probably the most common type that we see. This is usually the elderly patients, often a fall from a standing height. They rarely need emergency treatment, but sometimes they can catch you out because, as I say, these more frail patients have got worse physiology, worse soft tissues, worse bone, and they can have a bad outcome if we don't sort of give it the respect they need. So I'm not going to dwell on classification because there's umpteen classification systems, but there's one that's really commonly used and it's quite helpful because it looks at the mechanism of injury, and that's the Young and Burgess classification system. It's the one most people have heard of the bits of it, and it's broken down into the mechanism. So it's the AP compression, the front to back compression, and that's the open book fractures, the squash from the side, the lateral compression, the vertical shear, and then sometimes we see patients that we really can't fit into one of those categories, so we call them a combined mechanism. So if we look at each of those, the open book pelvis, the APC, this photo is borrowed from a colleague in Texas, but we don't tend to see too many rodeo accidents, but we do see an awful lot of motorbike accidents. So as you can imagine, patient has a rapid deceleration injury, their bike crashes into the side of a car, their pelvis hits the fuel tank as they're projected forward. You get this big dent on the fuel tank and their pelvis is split apart. And this is the type of injuries you get. So the classic APC or open pelvis, you get separation of the pubic symphysis, and usually you get a ligamentous injury at the back, so a disruption through the sacroiliac joint. And that can actually be quite subtle even with a bad injury. So this one on the left, we can see that the symphysis is pretty wide on that one, but the sacroiliac joint on that left side really doesn't look that dramatic. Whereas if we look at this one on the right side, we can see that the symphysis is massively open. You could get a fist in that. The left sacroiliac joint's completely dissociated. There's nothing attaching that sacroiliac joint together. Again, you could sort of get a fist in that. And that means that there's effectively nothing holding that person's lower limb onto their body apart from their skin and their nerves and their blood vessels and a few muscles if you're lucky. And you can see on this picture some of the other signs you sometimes see on the x-ray. Around the genitals here, you can see lots of air. So this is almost certainly an open fracture that's happened due to the severity of that disruption. So that's the open book ones, which are the ones we all worry about. Then the most common type is the lateral compression. So as I said, the fall from a standing height in the little old ladies or little old gentlemen will often give you a ramus fracture or a lateral compression injury, or you can get high energy sort of injuries from the side, the T-bone injury, as we can sort of see here. Now, we split these up, and it's not really important to know, but it's just important to know that they are all lateral compression injuries, so we can think about how we manage them, particularly regarding binders. So if we look at this first one, this is a lateral compression type 1. And what you get with that is a sacral fracture at the back, some ramus fractures at the front, and an internal rotation deformity of the pelvis. Now, there's a few other features we can see on this first x-ray. Apart from the fact it's a bit deformed, we can see that this person's got a binder on, which is entirely appropriate. They've come into hospital suspected to have a pelvic injury, but you can imagine that if that was done up a lot tighter, then they're going to potentially have even worse deformity. The other thing we can see is the dye here going up the urethra. Now, this is someone who's having a urethrogram done at the same time. Now, this is a normal urethrogram. This gives you an impression just how much the genitourinary system is pushed over to the side by these injuries, and how you can have that associated injury because it's all pushed over to that patient's right. Now, the type 2 lateral compression fractures, that's just where you've got an iliac wing fracture at the back rather than a sacral fracture. It's the only real difference. And again, you tend to get these ramus fractures at the front. And then finally, the worst type is where you have a lateral compression type 3, where one side of the pelvis is squashed in so far that it actually levers open the other side of the pelvis. So you get an external rotation deformity on this side. So usually the sacroiliac joint opens up there, and they've effectively been completely squashed flat, usually sort of being rolled over by something. And they're pretty serious injuries. And then the last of the sort of classically described is the vertical shear. We usually think about these, a patient landing on a leg, and I've got a video of someone who's sort of falling from the sky while parachuting, but actually, if you land on your leg, you tend to break your distal tibia or your tibial plateau. So it's actually usually that they land on their bum to do this. They land on their ischial tuberosity, and that shoves up that side of their pelvis. And what we can see here, if you look at their great sciatic notch, that should be down here where this side is. So this whole side is sheared up sort of 4 to 6 inches. So these are the patients who also potentially benefit from traction as well as a binder, and we'll talk a little bit about that in a bit. So diagnosis isn't usually too tricky for these patients because normally the mechanism gives it away. They will therefore normally have a major trauma CT, which is absolutely brilliant. It shows you an awful lot. The only times that we can potentially get caught out is because binders are so good and the pre-hospital teams are so good at getting them on that it can lead us to potentially underestimate the injuries. So this CT on the right, we can see it looks pretty normal. The only thing that suggests there's anything amiss is there's a transverse process fracture here on the left, but there's not really a lot else. But then when we take the patient's pelvic binder off, we can see that they've actually got a really pretty severe AP compression or open book pelvic fracture. So if you're suspicious of someone, if you're not able to examine that pubic symphysis, if they're asleep, if they're intubated, then it's really important to get an out of binder x-ray when you're clearing the pelvis once you've taken that binder off. And it doesn't need to be a clever x-ray, just a simple AP pelvis is all that's needed. You don't need inlet or outlet views or anything more fancy. So the emergency management of pelvic fractures is actually really, really straightforward. All we have to do is stabilise the ring and stabilise the patient. Now, vast majority of patients, all we're going to need to do to stabilise the ring is use a pelvic binder, and I'll talk a bit about those in a while. As I mentioned, those vertical shears, if you can see that a patient's leg is 6 inches short, then actually putting them in traction, it's going to be helpful for their neurological status, it's going to be better for controlling their pain, better for controlling their bleeding. When it comes to stabilising the patient over and above what the binder will do, these patients often need a big transfusion. We're talking double-figure units of blood and clotting products, and often they'll get a bit better, they'll get a bit worse, and we need to just not panic and keep putting the blood in until they stabilise. Obviously, the non-responders, we're going to have to do something else, but in the vast majority, that transfusion is going to be great. Making sure that they're warm, super important. That's usually the only useful thing I do when I attend a trauma call is I go and get the bear hugger and put it on the patient because I can't do a lot else helpful in ED. And then finally, we sometimes have to do direct control of the bleeding. So as I've said, the vast majority of patients, that initial stabilisation of the ring, Pelvic binders, fantastic. And we'll talk a little bit about how those are used in a sec. Now, rarely we have to use something else, but gone are the days where we say, oh, it's a really bad pelvic injury, go and put an X-Fix on down in ED. There's very few indications for doing anything like an X-Fix or a C-clamp. So the two pictures you can see here, this top one's an external fixator. So we can either put pins at the top, so that's great because we can sort of do it in a hurry. We don't need X-ray control. And letter A is the pin sites where we put it if we're planning to use it more for a definitive treatment. They're pretty awful for the patients though, and you wouldn't want it long term. The times we might use this, the times I've used it, is if they're having a laparotomy. That can be awkward for the binder, or if they've got a big vascular injury to the leg and the vascular surgeons or general surgeons need access to the groins for doing a vascular intervention. Now, interventional radiology don't always necessarily need you to get rid of a binder. Often you can just cut a piece out of the binder and they can go ahead and do their interventional radiology around that. But obviously that'll need to be liaised with them whether they've got good enough access. So X-Fixes, they're not brilliant because they're controlling the front of the pelvic ring, and actually the main action of a pelvic injury is at the back. It's where their pelvis is separated from their spine. So for that reason, there's this contraption called the C-clamp, which we only ever tend to pull out sort of at 3 o'clock in the morning on bank holiday weekends, and it's all a bit of a drama. But it's very good at squashing in the back of the pelvis. And this is only really used by pelvic surgeons, and you need X-ray control, because as you can imagine, those big horrible spikes, if those go in the great sciatic notches, they're going to do an awful lot of damage to that patient. So as I've said, pelvic binders, absolutely brilliant. They reduce movement at the pelvic ring, so they stop it hurting so much. They reduce the volume, they reduce the bleeding, and they often can get it so good that we can't even see the injury. We can leave them on for sort of 12, 24 hours without the worry of pressure effects, particularly around trochanters. And you shouldn't really need it for longer than that. It's designed as a hemostatic device. It's to stop them bleeding to death. People often talk about latch compression injuries and pelvic binders. As you saw earlier in that picture, that patient's pelvis was a bit internally rotated and they had a binder on, and people get stressed that they're going to cause damage to the patient. I would say that the force that goes through a human to break their pelvis, the violence that does that, is always going to be so much more than you're going to do with a pelvic binder, that don't worry about it. You know, if they've not perforated a viscera with a sharp bit of bone when it's traveling at high speed with loads of energy, you're not going to do it by gently tightening up a binder. And obviously, if you then get the imaging that shows it's an internally rotated, squashed in injury, then you can slacken the binder off. So rarely we have to do direct control of bleeding. And it then becomes the debate of whether it is an open procedure, so that's pelvic packing, or whether it's an interventional radiology procedure. And this is the sort of eternal debate, and it's one to be had between the pelvic team and the interventional radiologists based on the clinical picture, where the patient's going and what resources are available. Like if you've got a hybrid theatre, then it really doesn't matter which one you start with. So preperitoneal pelvic packing, this is where we put packs right down deep inside the pelvis. It's a different place to where general surgeons might pack a spleen. They're inside the peritoneum, we're outside the front of the peritoneum. You don't need to put an X-Fix on to do this, you can just leave a binder on. It does a great job of controlling the pelvic ring. And if the general surgeons are doing a laparotomy, we can just bring that down a bit further, lift up the peritoneum and get down into the true pelvis. Obviously, again, it's like a binder. They're just there to control that life-threatening hemorrhage, and they need to come out after 24, 48 hours. Otherwise, the patient will get septic. Now, I won't cross over too much with James about embolization, but obviously if there's a blush on CT, that indicates that there's some pretty brisk bleeding from an artery. And if the patient is stable enough to go to the interventional radiology suite, or if you're lucky enough to have a hybrid theatre, then interventional radiology is very minimally invasive, and it's great for these types of injuries, particularly if it's selective. If you just block off the the intern iliac, then they can potentially shed their buttock, which isn't something I've seen, but it is widely reported and obviously isn't ideal. Now, Reboa is something that people might have heard about. It's a sort of new thing, which we've been involved in some trials, used a lot in London, and that's the retrograde emergency balloon occlusion of the aorta. So effectively shoving a balloon up through the external iliac artery and putting a cross clamp on the aorta. And the important thing, I think, with Reboa is that that's exactly how it should be regarded. It is an aortic cross clamp. It's a tourniquet around half that person's body. So the second it's on, that person is going to have massive ischemia. So they're going to be getting acidotic, they're going to get cold. Therefore, you really need to have an exit plan with these patients. If you blow it up, you need to think, what am I going to do that allows me to get it down? So if that is, I'm going to theatre, if it is, I'm currently pre-hospital and I'm going to get the patient to a hospital where we can give them a massive blood transfusion, then that's great. And obviously it needs investigating with the trials that are ongoing. But if you're planning to rely on the patient's own ability to clot, which is what we do in the vast majority of pelvic fractures, actually making them cold and acidotic is going to be worse for their clotting. So it should be used with a bit of caution. So we do see associated injuries with pelvic fractures. I'll talk a bit about genitourinary injuries because you don't tend to see those very commonly not associated with pelvic fractures. Bowel and liver and spleen injuries, they're managed as they would be if it was any other sort of blunt or penetrating trauma by the general surgeons. So with genitourinary injuries, there's a few clinical signs which are potentially useful. So blood at the meatus, I think, is a really useful sign. If there is blood at the urethral meatus, then we need to have a high index of suspicion. But anybody with a displaced anterior pelvic ring injury, we should have a high index of suspicion. People talk about a high riding prostate as a clinical sign. I think if you've got someone with a bad pelvic fracture and you're trying to assess how high riding their prostate is, I think you're going to be in a, I don't know that that's going to be a useful thing to do, if I'm absolutely honest with you. The much more useful thing to do, if you are suspicious, is to get some imaging. So there's a few options which we can do. So we saw a picture earlier of a normal retrograde urethrogram, and that's effectively where we just put a normal bog standard Foley catheter into the urethral meatus and squirt a bit of dye up it and then take an x-ray. It's really easy to do. You just need to make sure you don't blow the balloon up too much, otherwise you damage the patient's urethra by doing it. If the patient's already had a catheter passed successfully, we can still do a urethrogram, because the last thing you want to do is take that catheter out, then find out they had a partial urethral injury and then you can't get the blooming thing back in. So we can actually sort of railroad a pediatric catheter alongside the catheter and put dye up alongside a catheter as well to see if there's any leak out from the urethra. So that tells us whether the urethra has been damaged. When we're looking at the bladder, we can either do a cystogram, so that's just where we have the catheter in place, either a urethral or suprapubic catheter, and then we just stick 500 mils of dye into the catheter and take an x-ray. There is actually, you can get a cystogram just from a normal CT. That's when the patient effectively processes the dye that they've had given intravenously. It goes through their kidneys, ends up in their bladder, and actually one of the pictures I've got in a sec, the patient hasn't had a formal cystogram, it's just that their bladder is filled with dye-stained urine. Regardless of whether you suspect a urethral injury or whether it's confirmed, it's possible to have a gentle pass of a catheter, and that's what the BOSE guidelines say. It says it should be someone experienced, but I would say that most F2s are probably pretty experienced at passing a catheter, and it's gentle. If it doesn't go, then the patient's going to need a suprapubic catheter, and that should be done in the midline, done via the guidelines, which is sort of Seldinger technique and a few other things. So here's a couple of pictures of some abnormal findings. So this patient has had a urethrogram, a retrograde urethrogram, and you can see it's pretty obvious all the dye that leaks out from the bulbous urethra. And then this is the image I was talking about. This is a chap who got run over by a van, and he actually hadn't had a cystogram or a urethrogram. This was just a Bastian protocol CT. So he processed the contrast from that. It ended up in his bladder, but because his bladder was leaking his urine, you can see all this dye leaks out into his retroperitoneum. And it's pretty easy. They're not subtle findings. So open fractures are a particular thing that we focus on. Thankfully, they're rare, but they are important, so we'll cover them on their own. There's various ways you can get an open fracture. The most common is that the pelvis is so badly deformed and pulled apart at the time of the injury, particularly with those open book or vertical shears, that effectively the bones fail or the ligaments fail, and then the soft tissues finally fail as well. So this is the sort of the trouser crease in the perineum, in the groins, and it can go into the genitourinary system or into the rectum as well. The other ways you can get open fractures, though, if you've got a bad lateral compression injury, those sharp bits of bone can stick into the bladder, into the vagina, into the bowel. You can get bad degloving injuries. We call that a Morel-Lavalley lesion. And sometimes the skin's so badly sheared off that it either is pulled open at the time of the injury or it later dies and then becomes open. And then finally, you can get these sort of penetration or blast injuries, which are obviously serious. Now, I would say that any open pelvic fracture is serious. Classically, it's documented that about half of these patients are going to die. I think with modern treatment, we would hope that less than 1 in 5 die from these types of injuries, but obviously it depends on the severity of it. If they're going to die from these, obviously they're often multiply injured patients. They can die from their head, chest, abdominal injury. But if the pelvis is going to get them, it's either that they bleed to death or they get late pelvic sepsis. And, this picture on the right, you're not going to miss that. That's obviously a really severe injury. But this one on the left, you can imagine how if that patient had a pelvic binder on, it would be really easy to miss that wound. And that patient could potentially not get the correct emergency treatment that they need. So as with any open fractures, we need to give these patients IV antibiotics as soon as hospital. Sometimes we can give that pre-hospital. If there's gross contaminants in the wound, either from the patient's GI tract or from the environment, then we can remove those. And we need to pack them because these patients, by their very nature, are often going to have a bleeding pelvic fracture. And you can imagine if that's going to normally fill up the retroperitoneum with blood, well, if their perineum's all open, it's just going to come out onto the road. So we can put in there whatever we like, whatever's needed. And these patients are all going to need to go to theatre. And it's either the timing as per a contaminated open fracture, because they're all contaminated. So that's within 6 hours. But often they're going to be so sick that they need to be rushed to theatre as an emergency. So one of the managements that we are going to need to do for the majority of open pelvic fractures is they're going to need a colostomy. Now, obviously, if they've got a bowel injury associated with it, if it's ripped into their rectum, then the colorectal surgeons are going to want to do a colostomy just to manage that colorectal injury. But actually, if you think about the patients who have a bad injury in the previous photo, or if you think about this patient who's got vacuum dressings on their perineum, if that patient's got feces coming out the normal way, that's just going to be an impossible wound to manage. It's going to be nigh on impossible even without that happening. So we will often ask the colorectal surgeons to do a colostomy for the patient just to allow us to manage the wounds better. So we make sure that colostomy is high and away from future surgery. They can often, if there's no bowel injury, if they're not doing a laparotomy, they can actually just do a laparoscopic colostomy. It's a really quick, sort of minimally invasive procedure. Our BOSE guideline says we should do a distal washout, which has always felt quite counterintuitive to me, to have an open fracture that you then flush lots of feculent water into. So we often don't do that. But that's why you might have a patient who presents later on down the line, who's got a colostomy, who actually had nothing on their initial CT to suggest a bowel injury because we've done it just for their wound management. So general principles of definitive management of pelvic injuries is try not to operate on them if we can avoid it. So if the injury is stable, if it's in a reasonable position, then we'll try not to do any surgery on them. It might be if we're worried about it moving in the future, or if it's going to move, if the person walks on it, then restrict their weight bearing, but they do need to be able to mobilize. And the examples of these is commonly the low energy lateral compression fractures, so that's your ramus fractures in elderly patients. Although we are moving towards potentially intervening in these patients, particularly if the patients are unable to walk. And we've actually just started a randomized controlled trial where if the patient's unable to walk after several days of attempting that, then we are going to randomize them to either fixing them or not to see whether it allows these patients to mobilize, because that's obviously super important in them. Now, if you've got an unstable injury, if it's deformed, if that pelvic ring is really wobbly, if they can't rehabilitate, then they're going to need some sort of intervention to put them back in place. Otherwise, they're going to end up with leg length discrepancies, sitting imbalance, all these problems. If they're a multiply injured patient, they're not going to be able to get out of bed. It feels pretty awful if you've got a wobbly pelvic fracture. So it allows that patient to rehabilitate. The sort of things we do, I won't go into too much detail, but sometimes we have to open it up to put it back together, and we put plates and screws in. Sometimes we can use long screws, and these are pretty cool because we can fix sometimes really bad, nasty pelvic fractures with tiny little stab incisions. The patients recover really quickly, which are great. And then this picture on the bottom right, this is an example of something called the infix. So traditionally, if patients had a bad injury at the front, if it is a complex injury where you'd have to open it up and spend hours piecing it all back together, you might have chosen in the past to use an X-fix. Now, that's a pretty awful thing to do to another human being. They hate it. It's really uncomfortable. They can't sit down very easily. Because there's so much movement at the pin sites, they get infected. So this infix uses the spinal pedicle screws, and it's tunneled under the skin at the front of the pelvis. And it effectively acts like an external fixator, but tunneled under the skin. So again, you will sometimes, if you see these patients, we try to make sure that that bar is actually stretching their skin a little bit. So don't panic if you ever see that, because if it's stretching the skin, by definition, it's hopefully not compressing their neurovascular structures, and it makes it a bit more comfortable for them as well. So as well as genitourinary injuries, unfortunately, you can get neurological injuries with pelvic fractures. And sometimes they can be quite hard to pick up. This one, I haven't shown all the axial slices, but when you have these injuries in the sacrum, hopefully we can all see that is potentially going to compress the cauda equina for this patient. But when you go through the axial slices on a CT, it comes across like this, and it just looks a bit weird. And without these reconstructions, it's really hard to see how bad that deformity is, because you just see, oh, there's a bit of sacrum, and then you get another slice, and there's a bit of sacrum. So it is important, and the radiologist will obviously go through all these reconstructions. But yeah, neurological injuries, fairly rare, but when they happen, obviously devastating for the patients. The important things to know is that any damage that are done to nerves is all, as with kind of spinal injuries really, it's done at the time of the injury, unfortunately. And for that reason, there isn't an urgent need to go in and decompress those nerves or reduce the fractures. And we don't normally need to intervene as an emergency because unfortunately the damage to the nerves has already happened. They are usually unstable though, so they're by definition going to need some form of fixation. Now, I'll just move a bit away from pelvic ring injuries, just because Caroline suggested this would be a topic to talk about as well. So that's native hip dislocations. So this is classically going to be a patient with an injury striking the knee, so commonly a dashboard or maybe a rugby player with lots of people landing on top of them, and it drives the hip out of the back of the socket, and they end up with a posterior dislocation. So these patients are going to present with their hip in a sort of flexed, internally rotated position. They might have a sciatic nerve injury. It's pretty common with these. Now, I'm happy for anyone to have a go at trying to put these back in the emergency department. Obviously, sedation is going to help. It's important to document the neurological status before and after reduction. But they're a bit sort of counterintuitive, these. But when you've got a bad looking fracture, so either an acetabular fracture or even a femoral head fracture, they're often actually easier to reduce because you've not got a big lip of posterior wall to get that femoral head back over. When it looks fine and there's no fracture, they can actually be a real devil to reduce. But by all means, have a go. You're unlikely to make them worse, and it is an emergency to get it back in. If there is a big fracture of the posterior wall, they can be really wobbly, and as soon as the patient internally rotates in bed, it's just going to fall out the back. So if you do see that fracture on any imaging, or if you're concerned, you could kind of do it in all cases really, then you can put some traction on them, and it just helps to prevent that falling out the back. Just some skin traction is absolutely great. So thinking about referrals to major trauma centres in the region, thankfully these days the ambulance service are so good at picking up the mechanisms that most high energy injuries that need to go to a major trauma centre where pelvic surgeons work will go there automatically, and all the other local trauma units and local receiving hospitals know the pathways to refer those patients in. Now, paediatric pelvic fractures in the Midlands is a bit of a special situation, so I thought I'd just clarify what the situation is. So BCH is our paediatric major trauma centre, and they've got pretty much every service that can be offered to injured children, but there aren't actually any pelvic surgeons that work there or can operate there. So they'll obviously manage patients that don't need surgery, but if the patients need surgery, then they will need to go elsewhere. Now, at UHCW, where I work, we're happy to fix any children's pelvic injuries, but if those children need ITU, either from their pelvic injury or from their other injuries, then they can't come to us because we've only got a bit of a sort of HDU type thing, and we don't have paediatric neurosurgery. If the patients need ITU, but they haven't got a brain injury or need neurosurgery, then Stoke are able to fix kids' pelvises and have an ITU for children. But if they need neurosurgery, even if it's not actual surgical intervention, and they need ITU, which often if they're having a pelvic injury and a brain injury they're going to, then unfortunately the nearest centre is Nottingham. And I've had children before now injured in Worcester who have been treated in Nottingham, which is obviously less than ideal. And we're working with BCH to see whether we could get operating rights to work there, because that would obviously be the most convenient rather than trying to put the other services into the other units. So consequences of a pelvic injury, unfortunately, they don't all do brilliantly, regardless of what treatment they get. Assuming they survive, a lot of them get chronic pain, usually around their back. If there's any deformity in the pelvis, any leg length discrepancy, they're going to dislike that. They might limp. And if there's any rotational or height deformity in a sort of vertical shear, as well as the leg length discrepancy when they walk, they actually have sitting imbalance, and they really hate that, which is why we often intervene with these patients. And unfortunately, it's not at all uncommon to have sort of sexual or genitourinary dysfunction, and all the hospitals have got referral pathways, all the major trauma centres, to get them through to andrologists and neurologists as appropriate. But as with all these things, the most important thing is actually just to talk to the patients, because the patients often don't offer this information up freely, and they won't get the right services if we don't talk to them about it. So to summarise on pelvic ring injuries, they're potentially life-threatening. They're certainly life-changing injuries for a lot of patients. We need to give them the respect they deserve, and if the mechanism is bad, then suspect that it's a bad injury, even if the imaging isn't looking too bad. The resuscitation on the whole is really straightforward. Binder, transfusion, keep them warm, and that's usually all that's required. It can be scary when you're getting up to unit 10, but we need to persevere with that. And all of the specialist centres have got good referral pathways, hopefully, and we're always happy to be involved. Thank you.
Lovely, thank you, John. Any questions? I've actually got one. What we're seeing, I know you're probably used to deal with pelvic injuries more in young patients, or those are the most impressive, and what you showed us were quite a few impressive images. What about the elderly population? Because what we see mostly is elderly pelvic trauma. Does that pose specific challenges?
Yeah, absolutely. So I think traditionally the elderly pelvic fractures we've treated with a bit of neglect. Really, we've said, oh, they're difficult to fix. The surgery traditionally has been big, which we've wanted to avoid in a frailer population. So we've just said, oh, well, they obviously all do fine with non-operative management and admit them under the physicians. You know, which almost certainly isn't the right thing to do for these patients. So for that reason, we're more and more going towards, I think, giving them the respect they deserve, even if we don't necessarily intervene. So I think the whole things that have moved on with silver traumas and things, we now appreciate the differences that happen in elderly people. But this trial should be good. So that's looking at the most common type, the lateral compression ones. Because if you put a elderly patient in bed for 6 weeks, they're going to have a really high risk of loads of complications. Whereas if we can do a really simple intervention like an infix, you know, it takes an hour, it's 2 little teeny tiny scars, then potentially we'll get them walking much quicker. But we don't know that without the trial. And again, hopefully with more of the percutaneous things, we are getting better at actually intervening in these older people. And with the acetabular fractures, again, elderly acetabular fractures is a big problem because, again, they've been really difficult to treat in the past. So we've said, oh, manage it non-operatively. Whereas now we're going more towards, well, what's the least invasive way we can actually get these patients walking and get them out of bed? So we are, as a group of pelvic surgeons, very much moving towards taking them seriously and intervening at times when appropriate.
I know, for example, for acetabular traumas, we tend, the TUs in the area tend to refer most of the patients towards you guys because our orthopedic surgeons don't have either the skills or the resources needed to deal with those patients, and they can be more complicated. What is the role of rehab for those patients in general? What time frames are we looking at? What kind of specialist teams are we looking at? Do we have those teams outside the major trauma centers?
Yeah, so I think we would want to know about anyone with a pelvic or acetabular injury who's not able to just get up and walk out of hospital. Because if they're struggling with that, then we would want to be advising on those. We would aim to try and have that patient in a situation where they can, as a minimum, be getting out of bed with physio and sitting out. So even if that's the frailest of the frail patients, we would want to be able to do that. So it's simple rehab. You know, we wouldn't want them to be hoist transferred. But as I say, if we've got somebody who's in so much pain from either a pelvic ring injury or an acetabular fracture, then we're really moving towards intervening on them to allow them to walk. It's kind of like that with all aspects of trauma these days. We must do any intervention necessary to allow that patient to mobilize. You know, non-weight bearing in an elderly patient is just an unacceptable plan these days. So hopefully the rehab should be made straightforward by the intervention.
Do you input in those rehab plans from the specialty? As in, even if the patients are outside your area, are you requested for that input in the rehab plan? Or
absolutely, yeah. So that the teams in other hospitals will liaise with us about weight bearing status, which I would hope would always be weight bearers tolerated in an elderly patient, and we'll put a plan in place for if they need further imaging and follow up. You know, we try to make it as convenient for the patients. I'm happy to see everyone, but I appreciate that a big trip up the motorway for an elderly patient might not be the best thing for them. So if it can be followed up locally and the guys are happy to do that locally, then we sort of mutually agree that. But no, we hopefully have a good relationship to do that.
I think our biggest takeaway from your session, for most of us, or a good number of us being emergency physicians, is the pelvis binder would not harm, and put it as early as possible.
Absolutely.
Before imaging. There is some reticence mostly in the junior pool, and we see that there is a lack of confidence in putting it and putting it properly, tying it properly. So I think that is a big takeaway from this session. And also, thank you ever so much for clarifying the pediatric pelvis injuries. I'm not sure that too many of us knew about the challenges you're facing at that end, because we only see the end of the services. We don't see the inside of it. So yeah, there is one more question for the public. Is there any specific orthopedic contraindication to the use of the infix, especially in elderly patients?
No, it tends to be pretty good, if I'm honest with you. I mean, they often, unfortunately, get numb thighs. So the nature of where it goes in, it tends to stretch their lateral femorocutaneous nerves. So that it gives them no motor deficit. But don't worry if patients are seen post-op and that you go, oh my God, they've got this massive area of numb skin. What's happened? I need to let them know straight away. It's super common. But no, we can do it in everyone. I mean, if it was an open fracture, with big sort of open wounds into the groins, then we probably would go more towards an X-fix and accept that it's unpleasant for the patient, but it would probably make it easier for wound management. But no, they're really good. They do come out. We take them out at about 3 months. So that is unfortunately a second short anaesthetic for the patient, but it's the patients tolerate them really well, and they don't mind it.
Lovely. Thank you ever so much. If there's are no more questions, we'll let you go. We do appreciate your intervention.
No worries. Thank you.
And I think now we're due for a lunch break for about 20-25 minutes. So grab some lunch. We'll meet you back at 12:10 for the last 2 sessions of our day. And yeah, see you in a bit.
Thanks, Andre.